All right, welcome everyone to our third meeting of the Emerging Technology Committee. Thank you all for being here. Before we get started, a couple of reminders. This meeting is being live streamed and a recording will be available on the dedicated webpage for the ETC. We also want to remind folks to use the Q&A feature as well as the chat throughout today's meeting. And if you have any technical questions, you can find my colleague Carson at Carson DeWeese, KHI, IT help, and she will help you get things figured out. Our agenda today is full as always, and we're going to start with welcome overview. I got a couple new members we want to welcome. We're going to do a quick charter approval, finalize that, and then we're going to spend the bulk of our time continuing RFP feedback and discussion. Then we'll wrap up at the end, looking forward to some upcoming aspects of our work together. So before we get into everything, I want to welcome a couple new members, and I know that Emily Brown is a liaison with KDHE, and she has joined us. Looking at the list of participants, see if she is here. Emily, I don't know if you're able to come off mute and say hello.
Yeah, hi, I'm Emily Brown. I am the PMO manager at Kansas, but I also oversee our RHTP Advisory Council.
Awesome. Thank you for being here. And another new person on the committee, and apologies for any mispronunciation, but Dr. Gugnani, are you
That's actually pretty good.
You want to introduce yourself?
Sure. Let me try to get the video working. I'm actually driving, so it makes it a little bit. I'm in a car, so anyway, PK Gugnani, practicing physician, Southeast Kansas. I'm also the Chief Informatics Officer and Chief Medical Informatics Officer as well for CHC SEK, and been in Southeast Kansas for about 20 years.
Awesome. Thank you so much for joining us, and travel safely, and thanks for joining while on the road as well. Well, moving us along, and thanks everyone. And if you feel like you want to reintroduce yourself in chat with your name and organization, feel welcome to do that. If there's some folks that seem new to you, but we're going to keep moving. We got a full agenda. Reminder, I'm part of our facilitation team here at the Kansas Health Institute. You're going to hear from both Sheena and Shelby later today, and they'll carry us forward in some other parts. But hopefully our faces and names are familiar at this point, and we're excited to play our role in this work. Reminder of the timeline of key activities. We are working on revising and continuing to provide that feedback for the RFP, the ambient AI. We're looking forward to the work plan and budget and our in-person meeting later this month. And there's some of those other reminders of some exciting things coming up. This is the rest of our meeting schedule, as well as where we're at today with meeting number 3. Continuing discussion of technology and RFP feedback. That's the bulk of our time today. So the last thing that I'm going to have us do before I turn it over to my colleagues and we can really dive into discussion and feedback is we just want to get a final approval on our charter. We sent this around, so hopefully everyone had a chance to review. Thank you for those that provided your approval and comments via the survey. But at this point, especially for those that we want to make sure everyone has a chance to provide their approval. So if you could show of hands, find the raise hand feature, and this will be a good practice for the rest of discussion today. If you could raise your hand if you are comfortable with approving the charter, And I'll just note that we had a couple comments on some specific activities and evaluations to consider that we're going to address in the work plan. So thank you, Scott and Kyle got a couple hands, Derek. And if you have questions or concerns about the charter, please put a message in chat and we can discuss those before we do some final approval. I'm waiting to see a few more hands before we. And maybe people are struggling to find the raise hand feature, but I'm looking at videos, so it looks like we have some consensus to move forward with the charter. Thank you all for raising hands and doing that. We wanted to make sure everyone had the chance to do that and to feel comfortable with the charter. And without further ado, you can lower your hands, and if you can't find that button, we'll help you out. Without further ado, I'm going to pass it to my colleagues. I'm going to pass to Shelby, and she's going to provide a recap of what was discussed yesterday. So thank you all for testing out raise hand and for approving the charter.
Awesome. Thank you so much, Wyatt. So we'll do a quick overview of what we discussed in our last meeting. So if we could go to the next slide. If you were here last time, you'll remember Matt Lara, as well as Marty Ross, gave a fantastic overview of what's currently going on within the Rural Health Transformation Program, specifically as it relates to technology. So the Emerging Technology Grant is $9.5 million in year one funding. This round is really focused on proven technologies only, so not early stage research and development, but that could open up in future rounds. So we know that technology is not just limited to Initiative 5. We can see different technology related programs embedded across all 5 initiatives. So a few of those that they called out in our last meeting are consumer tools like Thrive CBT and the Lifestyle app, remote patient monitoring, and then also some programs within the Anchor Hospital Advancement Program. So specifically looking at that Anchor Hospital Advancement Program, the AI EHR fund is a separate from that $9.5 million grant. So those are 2 distinct funding streams, not one number split 2 ways, just to provide a little bit more clarity around that. But I think the overall message for this recap is year one is really about launching and learning. The work that you all do as part of the Emerging Technology Committee will help shape the program into future years and really provide lessons throughout the entirety of the program. Next slide, please. So next we'll go over a recap of the conversation we had on the ambient AI RFP landscape themes. So 4 kind of main themes came up during that discussion. First, looking at adoption. So the group noticed that rural clinics not affiliated with those larger health systems tend to maybe move a little bit slower on adopting AI systems than their urban-based providers. So this can be impacted by things such as resources, affiliation, and capacity. So these are things that we'll just need to be cognizant of throughout the RFP process. On integration, the discussion really focused on EHR embedded tools tending to work best within that area. But it was noted that an imperfect tool still beats no tool. So just making sure that we're thinking about what are some of the better fits for our rural-based providers. And then for providers outside of Oracle, that's especially relevant for how we frame integration requirements within the RFP. So on pricing, the committee flagged that vendors seem to be moving from per user licenses to pay per use models, which will impact how year 2 budgets are built for those providers. And then finally, the group agreed that it would be beneficial to get some more information about what's going on in the field. So we kind of see 2 different ways of that happening. So first, a needs assessment, which will be discussed later today, will be conducted by CHRI. And then we also, the group saw value in potentially doing an RFI to learn about what EHR systems providers are using and who may plan to apply for this grant. So going to the next slide, these are some of the kind of open questions that the group rose during the conversation, but we weren't able to address them entirely. So some of these questions, they're very familiar. We're going to be discussing them at length today. But on eligibility and priorities, a few different areas that came up were multi-site entities. So are they eligible to apply for these funds? And if so, would that be one application or several? Also working through which types of facilities may qualify for this funding in year one, and how to weigh readiness, need, geography, and data sharing. On requirements, you'll see that most of these come from our earlier discussions in the second meeting, things like transparency, privacy, bias mitigation, and rule-proven vendors are something that we'll be discussing further today. And then finally, just as a flag for that July 29th conversation, that will be done in Topeka at the KHI building, and that will be kind of like our last stage to wrap up these RFP discussions. So with that, I'll go ahead and hand it over to Sheena to lead us through today's RFP conversation.
Thank you so much, Wyatt and Shelby, and thanks for the new members and for all of you for joining us today. We'll just get right into it, unless there's any other questions about what we've shared so far. All right, well, if you have questions as we go, feel free to come off mute, raise your hand, or place the questions in the chat, and between the few of us that are on, we will make sure to pause and make time for that. All right. Okay, so as Shelby mentioned, we got into the eligibility discussion a little bit last meeting, but still have work to do in that area. So we will focus today on eligibility, and we will go into requirements as well, both thinking through use cases and vendor requirements. But for now, you'll see the blue square is focused on eligibility, so we're going to go ahead and start our continued discussion on that. All right, and so Kristen and I are going to tag team through the discussion today. We have set aside quite a bit of time so we can make sure we're really gathering engaged and thoughtful approaches to eligibility for the ambient listening AI RFP. So I'll turn it over to Kristen now, and she can walk you through a few key terms that are not just related to this RFP, but can be making sure we're on the same page as we move through the process for various activities with the group.
Great. Thank you, Sheena. As Sheena just mentioned, we wanted to make sure everyone's aligned on what these terms mean as we dive into really defining what our technology, operational, cultural requirements are. But also, as we finish the ambient AI use case, we are going to be coming back to this group and saying, let's identify what those next two greatest use cases are. So as we come back to this, we're going to use this as kind of evergreen language. Interoperability, lots of different definitions that sit behind that, and depending upon which governing body we're looking at, we are really talking about the ability for our systems and our data to be able to integrate for the purpose of doing the defined job that we are addressing. And that defined job is what we are identifying as the use case. So we will be starting each time with defining what are those biggest problem statements or needs that all of you are trying to address, and then defining the use case or the job to be done and addressing it. And that's going to be creating that story around who needs to be completing the job, what are the greatest hurdles, and that allows us to really start to dive into then what are those requirements. And requirements should be something that we can define very specifically. In many instances, we're talking technological or technology requirements. We'll get a little bit more into that as we go on. But it's also understanding what are the operational, the clinical, the cultural, and operational challenges that you have or needs in order for that technology to deliver or for that job to be done. So we're going to start today digging into some of those, and then we will follow up with an additional assessment after today's meeting. And we've also created tools that you can share with facilities that you support as well. interpretability, as we think through this, it is saying that whatever we develop, whatever solution or technology that we put in place, that it is able to be understood and verified by the individuals using it, whether that's AI or other technology or digital tools, that the end user is able to make sense of the output and ensure that it is meeting the outcome metrics and solving for the job. And data sharing is really about how the data for our patients moves between the different facilities or caregivers in order to be able to provide that care for the patient or solve for that job. So this has to do with data sharing between the third-party vendors, across systems, within our EHR, and then any additional third parties or from one facility to the other. There will be some additional requirements that we talk through from a privacy and governance security standpoint. There will be very specific that may be unique to your facility, and then standard ones that we will set, as we talked about last time, kind of those standard requirements that we're able to provide to any party that we are going to be partnering with. I think we can jump to the next slide. Okay, so as we get through those terms, and I actually should pause and ask if anyone has any quick question around those terms, or if that seems those are pretty straightforward for everyone.
This is Aaron from Stormontvale. I don't know about around the terms, but just in terms of the RFP in general, our goal is to select, maybe my question is being answered here, select vendors. So either one or more vendors, is that correct?
Correct. So, and we are talking for this ambient AI listening, this use case is for non-Oracle only. And ideally, we could get to one, but as we define what those requirements are, we may find that there is not one partner, one vendor that will address all of those optimally, and that we will need to use more than one as we look across the different EMRs.
Right. And I think as we dig into that, we may find that Oracle's not all that special in terms of the embedded technology working better than other technologies that can be applied. But we can dig into that more.
Okay. I
Well,
think it's
in addition, sorry, I was going to say is, sorry. I mean, a lot of different users have a lot of different EMRs. So have we actually gone through and figured out who has what? And because I mean, ECW, which is what we use, I mean, we've already been using their product called Suno, which is an AI, and we have a few people, we have several people that are on it. We've also been looking into Epic, and Epic uses Dragon or Nuance Medical One. So I mean, there's a lot of different places out there, but I haven't seen one that works with everything combined.
Dr. Gugnani, thank you for that point. And yes, we do not have all of that information yet. And actually, as we talked about the assessment that's going to be going out after this, those are questions that we are asking. And if you are using something different within the hospital versus in your clinics, we want to understand that. That will go into what those requirements are, as well as we know some different providers are already using tools. We want to understand what they're using and what is working and what isn't. And then this is kind of a multi-step process. We began it during our last meeting, and we will be completing the full requirement definitions in our in-person meeting. But today we'll go deeper on a lot of the cultural and operational pieces. And then to your point, we'll be getting a much deeper assessment from a technology standpoint and a follow-up assessment that will go out to everyone.
Okay, thank you.
Sure. Great questions. And so really, this is just to kind of walk through for this specific use case of ambient listening. The user need and use case were identified in part of the early on RHTP process. And so that came to us with ETC as here is one of the first use cases we'd like you to focus on. So we're really jumping into understanding more of the nuance behind the ambient listening, to understanding the landscape, and then getting into defining the requirements. And that's where we're focused on today. Just to give you all a really high level overview, once we go through those requirements, we will be defining the RFP. It will come back to this group for final approval. We'll launch the RFP and then come back with a curated list of vendor partners. We'll do demos for all of those vendor partners, score them across the matrix. This group will be part of each step of that process and then have a final recommendation for the vendor partner or partners to move forward with. All of that occurs between now and end of October, which will be through that year one RHTP program. So still a lot to do, but we're really going to focus on those two dark blue today and in our next meeting of getting deeper into defining what those requirements are.
Okay, thank you, Kristen. And if you have any other questions related to the process, just throw them in the chat. But now we're going to begin that process of talking through who should be eligible for receiving funding for ambient listening AI. And then we will jump back to working through that assessment that Kristen mentioned following the eligibility conversation. So we've used this tool throughout our meeting so far, but for those of you who are new, Shelby will be putting the link to the Padlet in the chat. And so we just ask you to go in the upper right-hand corner to change your name by clicking on the icon in the upper right-hand corner, change your name, and then in order to comment, we'll walk you through each section, and so we'll kind of do it all together. And as always, if you would feel more comfortable not using the Padlet, we know it's a little difficult if you're joining via phone, please enter your comments into the chat. The facilitators will enter it into the Padlet for you, and we absolutely encourage live discussion. That's what this is all about. So please discuss and as well and come off mute and share thoughts, and we'll make sure everything gets incorporated. It's just a way that we can record all of our conversations and be transparent about the process. All right. So I will give you a minute or so to get logged in, and then we'll begin. All right. So for the first section of topics related to eligibility, we're going to be asking you what are the eligibility criteria for potential applicants. We'll be going through rurality, talking through the sites that should be eligible and the types of facilities. So I'll turn this over to the Padlet and we will get going. All right, so first off, we're going to be talking about rurality. Should eligibility be limited to entities in rural areas, or should facilities that serve rural populations from a non-rural location also qualify? So thinking about who this funding is intended for, who it should go to, what are your thoughts about the systems that should receive the funding? Should it be big systems that have smaller rural entities, or should it be smaller rural entities alone? Like theoretically, how should this work?
I mean, in all honesty, I would think that if we can give the funding to those people that are actually in the rural areas, it'd be much better than going to the larger systems, particularly like KU or even Children's Mercy, which got, Children's Mercy's in Missouri and they got a whole bunch of money from Kansas for rural as well. So that would just be what I would say.
Okay. Thank you. Shelby, can you put the link to the Padlet in again?
Do you want the comments verbally or do you want them in Padlet?
Either way, verbally is fine.
All right. I think the preference should be given to, preference to organizations that are designated in rural areas serving rural communities. But I don't think you can overlook the fact that you have, metropolitan systems, including Children's Mercy, that provide a lot of services in those rural communities. So I think if you're talking about preference, I think you have to start with Frontier and, designated rural sites. But I think when we fold back into the metropolitan sites that serve rural, I think one, they probably have the resources, maybe already have a strategy. So
Right. And I'm not even disagreeing with that. You're absolutely right. I think we should start with the rural, and then, if there's stuff left over, then we can focus on helping those larger facilities. But a lot of the times they have that infrastructure already in place, especially with KU, which does have a lot of telemedicine as well. So
I, that's fair. I agree.
All right, Terry, I see your hand raised.
And I apologize for this question because I should probably know the answer, but in case others on this call don't specifically know the answer, the intent of the Rural Health Transformation Program funding specifically, was it for rural providers, rural patients, or both?
That might be a Marty question. Marty, are you on?
The notice of funding opportunity states that funds may be awarded to urban facilities so long as the primary beneficiary is a rural facility. So for the example of the Children's Mercy Award that was made under the Regional Partnership Grant Program, the Children's Mercy is receiving will be deployed in rural areas exclusively.
Okay, so based on that, and Dick and Dr. Gugnani, I agreed with what you were saying. I just wanted to get my mind clear on it, but based on that, I do think there should be some priority given to rural facilities. Or that rural facilities benefiting from the technology, and then, like you said, maybe then have a kind of some type of a tiered system so that there's points associated with being rural.
no, I would agree. I don't have any problems with that either.
Yeah, just to clarify, I mean, the intention at least at this point in time, and certainly things can change as the year 2 budgeting planning goes forward, but the intention has been for this program to fund the product for the defined eligible population, and looking to this group to help define what that would be. So, and these are a lot of the issues that we grappled with in the evidence-based practice program and defining the eligible providers there. They come into a different view here. I mean, for example, if you have an urban health system that has clinics or hospitals that are located in rural areas, that's one question. Should they be funded for purposes of placing the technology in the rural facilities? And certainly, just to make very clear, though, one thing we cannot do is reimburse a product that was previously purchased. So if a clinic has already implemented this tool, there would be no funds available to pay them back for that investment. Instead, if they would choose to move for a different product that had been identified by this emerging tech committee, then that would be their opportunity.
Yes, that does. I wish they could relook at that. I mean, that's just not realistic for a lot of people. But I know that's how it's
That's
stated.
RHTP rules. That's just you can't replace funds already expended.
Marty or Sheena, this is Chad with the Hospital Association. Just a quick question. What are the dollar amounts that we're talking about for helping assist rural providers with this initiative?
The preliminary amount, Chad, in the original year 1 budget had been just at 6 million. And that's separate from the Oracle investment. There are about 40 rural facilities on Oracle that was treated separately. There's a separate budget line item for that. The amount for non-Oracle was 6 million. That amount got pushed to year 2 for purposes of this process, for identifying the technologies on behalf of the rural providers who can then request the funds to acquire the product.
And recognizing how much it costs to implement something like this, like $6 million, is that only a handful of facilities that we're anticipating, or do we have an idea as to how many might actually be able to benefit based upon that dollar amount for year one?
Yeah, it was hardly scientific, Chad. I will admit to that very quickly. In that we did a rough estimate of the number of rural practices and the average patient side and the average number of notes. And that's how we ended up with what was a total of $12 million for this specific line item. So it was a placeholder at best. It was a wild guess, is more accurate.
I think it's actually really significant amount of funding. I think if it's 40 facilities for 6 million for the Oracle sites, you may not get that same yield because of some economies of scale that you've got there. But I think the bigger risk here is the changing nature of the business model from the people selling the technology. And I think that's the one we just don't know.
Like, Dick, we're experiencing that because we had kind of estimated, we had a more accurate estimate on Oracle, but that was at a per line basis, and now they're going to per connection. And so, but it's not changing the amount that much, as at least as I see it so far. We're just still waiting to get the final numbers on Oracle. And so I'm not sure exactly, but you're right. That's been one of the challenges.
Yeah, but I mean, I think this is meaningful. I mean, we know some of the providers that have wanted to get into rural, and at 50 grand a shot, which can provide a lot of that service, that can go a long way. I mean, you're talking, scores of providers that could be impacted here. So I think, Chad, this is a really good, because if you think about who's left after the 40 that go into Oracle, those that are in the metropolitan area, and you're talking, what, 40, 50 hospitals left, 60? I don't know what the exact number would be. I think this is a lot of coverage. And I think also we're looking for value. I'm not, I don't want to buy cheap, but I think you're looking for people that see an opportunity to get some scale selling into this environment. So I think we should, be expecting some pretty good value.
This is Scott, and just speaking strictly around the Oracle stuff, yes, that is a significant amount. I don't see us coming near to spending what we had initially anticipated with this, and I think it speaks to the scaling, like that was mentioned, and like you mentioned, Dick, the scaling to the other facilities that may not all go with one product. Yeah, even with that scaling, I think that 12 million is going to be very helpful for overall. And I'm not just talking hospitals, but independent clinics and everybody else as well.
Sorry to interrupt again, but as you see, I have lots and lots of questions. How would this Oracle one work with, say, somebody who's already got Epic or ECW? Would this be paying for having integration with that, or no, it would only be with Oracle sites? Or I'm a little confused on that one.
As I understand it, good, Scott. Go ahead.
Yeah. For right now, we are just focused on Oracle facilities, the way it's integrated within the EHR and how they've built and their strategy around their whole clinical AI and workflow and everything and how it plays. Right now, we only have it deployed with Oracle. I have not had some conversations about what this looks like as a standalone or integration with another EHR, but it's not saying it won't work, because it really does use some separate computing power separate from the community works domains currently. But what that looks like, obviously Oracle's going to focus on their product first and the tight integration that it has. But I mean, they're to the point where they're ready to roll out orders and the draft orders, which I'm not saying the other vendors aren't either, but draft orders, coding, and other workflows based upon the AI ambient agent right now.
And once we complete those requirements, if Oracle has a product that will integrate with the other EMRs, or we believe meets all of those requirements, they will certainly fit into that consideration set of vendors. And as Scott and the Oracle team or Cerner team have really defined what the additional functionality is. We are looking to be able to create as much apples to apples on the products or the vendors that we end up bringing to play on the non-Oracle EMRs as well.
So look, we've done at Digital Health Cases, we've done a little bit of work trying to figure out like how this stuff actually gets to market. You're going to have independent ambient listening providers who have a bolt-on solution and the interoperability that Kristen talked about. You're going to have suppliers who are the system of record in the practices and the hospitals that will have an add-on that they believe is functional and already integrated into workflow. And I think those are the two pathways you're going to be looking at. And I think what you all talked about is having a survey of, because I think you'll know pretty quickly if, eClinical works and, well, QuadraMed, whatever, I can't remember all the names of these things, they change, but whatever's the current name of that, those providers will certainly say they've got this figured out, right? Because they want to maintain their base of clients. And I think that's part of what we'll learn is, do they really have it figured out? Is it really demonstrable? Is it affordable? Is it a business model that can scale as more providers come on? So I think we're just in that learning side of what's the market, how the market's going to approach this rural community. I wasn't part of the decision, but when you got 40 sites on one supplier and you've got business models that aggregate them already, that's easy peasy. I mean, that was a good way to accelerate value into the rural community.
All right. Well, thank you so much for all of the great comments and points. If you have any other thoughts on how it might work in practice, please put that in the Padlet or share in the chat. For instance, I'm thinking of an example. It could be, I hear that want to give preference to rural sites, but there's acknowledgement that more urban systems have rural sites that may need to be brought on board. So if they don't already have an existing system, there may be an opportunity to compromise and provide startup costs just to bring the rural sites a tool. So something like that. I'm just giving it as an example, but if you have any other ideas or thoughts about that, please enter it in. I'm going to move us along to multi-site grantees, and this is a continued discussion around how it might work in practice. So Shelby has put the questions in the chat. It's also on the Padlet. So as you think about how this will work, should entities that operate multiple sites be eligible to apply on behalf of all their locations? So say, for instance, I'm just throwing this out there. If Hayes Medical Center wants to apply, but they have multiple, would you all want to accept one application on behalf of multiple sites, or would it be prudent to have each clinic apply separately? That's one question. Again, should urban systems with rural facilities be eligible? Also, if a multi-site entity is eligible, should funding or scope be tied to the number of qualifying sites? And how should it be handled when a system includes both non-rural and rural sites? So different ways to attack the same question, but if you have thoughts about that, about different sites, and in terms of how the application should work, please enter them, come off mute, or share in chat. Did guys see entities that operate multiple sites should be able to apply on their behalf if they're controlling the controlling management entity?
There are management agreements that operate those facilities. If those are in place, I think they should be able to apply if they're running it. I think that's they're the controlling entity. Not if they have an affiliation or they have a program with, but they'd have to be managing the site under, a documented management agreement.
Okay, so we could potentially require them to include their management agreement or some proof of that.
Yeah,
okay.
what happens in this world of affiliations is everybody says, "Oh, well, I have a program with, so I'm going to apply." No, 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 no. They have to, just because you're connected through a telemedicine relationship. But if you're if you're in a management agreement with Hayes Med and they're running the place and they have the right to put the leadership team in place, even though you might have a community board, I think it's where the management control is. If you're in management control of the entity, I think you should be able to apply. That's my opinion.
What kinds
You
of
might know better.
information?
These exist.
Oh, no.
So I'm not an expert on where all those relationships are and what you guys consider a controlling entity. So
What kinds of information should the systems be required to provide for the entities that they're applying on their behalf? In terms of rurality, patient volume, etc., if any.
I mean, something more than just an MOU, and I think patient volume is actually a really good way to show that they're actually doing something.
Okay.
yeah, that's a really good observation. Yeah, it can't just be we've got an agreement, piece of paper. There ought to be, patient flow and some documented.
Right, because I mean, lots of people have an MOU in place, and then they'll apply for a grant, and then the people they had the MOU with never see anything from the grant in the first place. So at least this way, if there's patient volume attached to it, there's actual skin in the game.
Maybe to do a little bit of follow-up from Dick's comment as well, related to management agreements or what have you. I know we have a number of networks within Kansas, including the Great Plains Health Network, or that does not necessarily have management agreement with everything. And so even though there's a partnership, I think if there's a partnership out there, I think to me that would satisfy me. But I just wanted to share my opinion that we do have some relationships and affiliations that don't have management control that could partner together, which would make it easier for some of these facilities or entities to be able to apply on behalf of a larger group.
Yeah, so balancing the ease of application process and kind of barrier to entry with also proving, they would be working together in order to bring the system online. Okay. All right, and I see your comment, Chad, in the Padlet too. Thank you. All right, any other thoughts on sites and how it should work in practice?
Yeah, I would say I think this can be a hot topic on the urban sites that have rural connections. I think you're going to have to come up with a firm delineation that it can't just go to pay for IT infrastructure that somehow gets parsed out through, your management contract or whatever. I think they have to be able to document specifically what the license fees, the implementation fees, the operating fees are based on the volume and the support of that rural facility. So they already are structured to have some shared cost structure, I would think. But you're going to have to, in the RFP, delineate specifically how this money is funding the direct cost associated with supporting the rural facility, understanding that there is some percentage that's part of system overhead. So it's almost like a direct indirect cost. But I think you don't want a place that comes back and has 65% indirect and 35% direct. And I think that's just you're paying for the entire system infrastructure. So I would just be very specific on the dollars are going to fund the activity, the implementation, the support, and the licensing.
And Dick, I think to that point, my experience is really, I think patient volume is good too. And then also provider user, whether it's, a physician or APP or whatever, they're able to at least quantify on the vendor end of, if you have this many number of quote unquote users and broken down by their, practice type, then they can actually give you some number of costs directly related to those numbers. So maybe we can kind of say, who are actual rural practicing providers and trying to at least understand the usage count there, and then make sure those dollars are from a licenses or support and maintenance and implementation that kind of breaks down into that.
Yeah, that's a great observation, and that's real world experience there. So thank you.
All right, thanks. And for those individuals on the call that, have urban assistance with rural clinics or satellites, what are your thoughts about these particular questions that the group is weighing?
I would say,
And vice
I think
versa.
that's, yeah, no, I think that, the purpose of this funding is to serve the rural population. So I think the more we can do to make sure that that's where the funds are flowing, I think that'll be great. And then the reason I mentioned about the user specifically is, I'm having deployed to different types of users. So the AI ambient for nurses is quite different than physicians, right? And their workflow and how it's used and how much it consumes the technology. And so I think basing it all on things like patient volume and types of users and the number of users and their role really kind of, I think, helps make sure they're the ones actually practicing in the rural community versus urban. And I believe those applying for it should be able to hopefully articulate that.
Okay. So it's really about getting to details on what should be required, or what, if urban systems will apply, like what the funds will directly be used for and how they'll distribute them. Makes sense. Okay. I am going to move us along to type of facilities. So thinking about facility types that should be eligible, thinking about hospitals, but also other kinds of facilities like long-term care, primary care clinics, behavioral health providers. Initially, I believe that, and Marty can provide some more context on who will initially be eligible, but there are various types of facilities that could benefit from an ambient listening AI. What kinds of facilities would you think should be prioritized for this RFP?
Well, let's try that from a different direction. Are there any providers that should not be eligible? Because as you know, the state's grant programs have been very broad in their definition of eligible providers.
Do we have we've defined provider, right? I mean, is it someone who can place orders and bill insurance companies kind of thing?
I think we've been thinking more of the entity that would be awarded funds to purchase the products.
So I think that's why I think the word provider is a little challenging,
right?
Because there are an enormous amount of independent providers.
Not as many independent rural physician clinics as you would think there are.
Not in clinics, but people that can place an order, a medical order, and can get reimbursed. Now I know we've got Kansas Board of Healing Art, there's a lot of like who decides these things, but I think we're talking about serving organizations, right?
One example, and I take back what I said before, because the definition of provider for the grant programs has not included chiropractors, for example.
Okay.
Trying to think of other types of providers that.
How about podiatry?
I think they're considered physician practices.
Okay.
What a dentistry?
I think dentistry we have not included.
Okay. Licensed social worker? Because some LSCWs can actually do place orders, depending on if they're an FQHC and whether they can get billing or not.
Exactly.
And I think,
That's why those are some examples of people.
I think I mean, to the extent that they're practicing within an FQHC, are practicing within a CCBHC, certainly they'd be covered because the entity would be focused on as the FQ or the CCBHC, and
Right.
they'd be the recipient.
So, I mean, in specific for this program, then, I mean, we're kind of looking for more, I guess, the who is doing it. Because if it's going to be just I mean, if we just give it to, say, we give it to nursing homes, you don't really know exactly. Hopefully, you think that it's only the physicians that are giving the order, or APPs, or whoever the providers are. But there could be other people. Wound care could be considered as one of those. And they do have the wound care nurses that work under a set of generalized orders that providers have put in. So, long story short, I don't really have a great answer for this. But we can, make it endless and keep going and going and going.
Right. Right.
Well, I think so you want community mental health, right? I mean, that's something that I think we've talked about. We have representative from that area as well. You certainly want people that operate as hospitals. You want practices, and they could be single physician practices, right? Is that something you want to consider?
I think that's the core. That's the core at FQHCs. I guess those would be part of the clinic category you're referring to, Dick. But I think that's sort of the core. It's the question of the chiropractors, the dentists, the nursing facilities, who are also, I mean, they're also generating a written record of the services that they provide. That's sort of the core solution. That's the core problem we're trying to solve, is how to make that process more efficient.
Well, I mean, as for long-term care facilities, I actually kind of think we might be able to take that one out, because if the providers that are providing services there are already getting the ambient through their own organization, then they may not necessarily need a ambient listening device in the facility. So I'll use an example. When I'm in the hospital making rounds, I'm using a different one on my phone, and when I'm in my office, I use a different one on my phone. So each organization already has something different. So whenever I go to the nursing home, I just document in, my regular note. So I already have it in there. So for that reason, I don't think long-term care facilities should be there, but hospitals, primary care clinics, and yes, even individuals that could qualify for it, and definitely behavioral health. Because I think the ambient part for behavioral health would be a complete game changer for them, because their notes take forever, and then they don't lock them, and then we can't bill.
So I'll reflect just on the last time we made big investments in health IT with the American Reinvestment Recovery Act. We included hospitals and physician practices. We did not include public health. We did not include dentistry. We left off, half of healthcare, which is why you saw over the last 15 years rapid, adoption within those areas. So I think if the goal is to improve and sustain rural health through rural health and care providers, maybe that's a lens we could use. Like, you're not, there's all kinds of clinics out there that, wellness clinics and stuff. I don't know what the prevalence you'd find in communities, but chiropractor, the range of what chiropractors do now is pretty broad, in terms of their business model. I think we just need to be, and Marty, I know you're like, that's part where you have to decide, but maybe it's a list of who's eligible in this round one. Maybe we talk about it as, for this phase of 6 million in year, the funding we're trying to do in year 1, year 2. Maybe you make that list, and then, other considerations for future years, because there's, it's a 5-year program.
Dr. Totten?
Yeah, thanks. Honestly, like that comment right there makes a lot of sense. Just keeping in mind that this isn't one and done, and we've got a lot of work over a handful of years to look at this program and different applications. Because my initial thoughts it went really around all of these questions, and particularly like when we kind of get into the trying to compare apples to oranges when we look at different organizations and what's considered rural Southeast Kansas versus rural Northwest Kansas. I mean, whether or not one facility is using the same EHR from the rural health clinic into their hospital and then into the affiliated nursing homes, it's just we're not going to see consistency across the board in my experience with that. And so limiting, my initial thought was limiting to saying we don't want any applications from nursing home facilities. That's I would start to have a little bit of a concern with that just based off of how poor interoperability is between even within one organization. I've witnessed that in really rural frontier areas where they would they're salivating over and being able to put an application like this to just be able to streamline, not use 3 different EHRs because they're at different facilities. So long story short, I'm trying to say that I know we have to draw a line in the sand on some of these applications, but I would really just kind of advocate and push for making it as lenient as possible in terms of let's let different places put in applications just in case there are some ideas or considerations that we're not making here today that if we find out later down the road in hindsight, oh, if we would have known if it was going to be organization A, B, or C requesting products X, Y, and Z, that does make a lot of sense. But because of a decision to exclude someone here today, based off of a really high level criteria that wasn't able to be submitted. So just trying to keep it as general as possible, but recognizing that, yeah, I mean, I know we have to make some tough decisions in terms of rurality and urban organizations, but I'd like to see as many applications as we can.
Thank you so much. All right, any other thoughts on types of facilities? Okay. I'm going to move us along. Now we're going to switch to talk about geographic distribution. This was something that was mentioned in the first round of the RFP around ensuring that awards reach a spread of regions across the state rather than just concentrating in a few areas. So this question is really assessing whether the group wants to, is that a priority for this group, or is it just based on need solely alone? So do you want to ensure awards reach the spread of regions across the state, or how should they be geographically distributed or thought about?
Could there be some kind of a point system? I said something about point systems earlier, so sorry for sticking on that, but could there be some kind of a point system for a frontier provider? I mean, because they're usually really small and don't have the funding, and then maybe rural and like a geographic type locale as opposed to, or maybe population or something like that. I don't know, but I feel like if we don't try to spread out, we are going to see pockets.
Dr. Todd, do you have your hand raised again?
Yeah, and also just all those are great points. I know we've talked a lot about the volumes that some of these providers are serving, but to your point, with these frontier communities, if it's possible with maybe like KHA data or some other source of how far it is to the nearest specialty provider, how far it is to the nearest cardiologist. A lot of times we consider with our obstetrical deserts in rural Kansas, we take into account, is it over an hour and a half to the nearest baby delivering provider? And so just keeping all the above in mind and maybe using that as a data source as well as just the distance to the nearest source of care or specialty care.
I think if nothing else, to build confidence in the program, it needs geographic diversity. You see concerns over Children's Mercy, um, which is located in Missouri and in Kansas, by the way. They have Kansas facilities. Um, and even though I think that's the right call and in serving children throughout the region because of their reach, it does raise some political like, what the hell are we doing giving it to Missouri provider? And since we also do a lot of work on the Missouri side, I hear it obviously on the other side. Um, so I think I think you start with the need, but I also think in the early part of the program, you're building confidence that RHTP dollars are serving the state as a whole and serving its citizens. And so I think this is a really important time to demonstrate that. So I would vote pretty heavily that you'd want, broad, I mean, not, but you want Northwest, you want Southwest. I think that's going to be really important for people feeling like this has been fair and they've been listened to.
Given the volume of folks that you're contracting on behalf of too, you've got a little bit of leverage there. You may be able to structure it with vendors that there's flexibility in terms of the number of facilities, and they understand that they're taking on an effort that's pretty broad. The other thing I'd say is some of the infrastructure pieces that people have commented on, myself included, in terms of what's available within rural facilities. There's more than just the technology piece of things when you're implementing ambient. There's a lot of training. There's a change in terms of how people practice. And I think you've got to keep that in mind as you're issuing a proposal as well.
Yeah, I think, to Aaron's point, our observation and experience is that and these ambient AI tools are evolving to include not just the documentation, but even, clinical decision support and others. And so, I think that thinking through on supportability for long term is also going to be, I think, important as well to see who, not just from a training perspective, but make sure that we have a sustainability model around make sure these facilities and others will be able to support the maturity of the technology.
All right, thank you so much. In the interest of time, I'm going to move us along to our next eligibility question. This is really around sorry about that. My computer decided to freeze. Technical and organizational readiness. Thank you, Shelby. So go ahead and put both questions in the chat, if you will. It's also on the Padlet. So thinking about ensuring awards reach a spread of regions across the state, rather than concentrating in a few areas, which we just discussed. Thinking about workforce and clinician engagement. Should applicants demonstrate clinician buy-in or a plan for staff training and change management? And that's kind of to your comment, Aaron, about there's more than just the technology. What other things should be in place to, or for us, the committee, to assess whether or not the organization is ready to receive funding and implement it accordingly?
I mean, this one is so obvious to me. I mean, I know it's a nice question to have, but of course.
Of course.
I think it's really, really critical. And I think also, so if we've talked to some companies, they think they want to serve this environment. I mean, I think they're really well intentioned, but we were describing how you get to certain places. They're like, well, we can fly them. Like, you can't fly in. You're not commercially. And well, how far is it from Manhattan? I'm like, it's still a couple hour drive. Okay. They're like, oh, wow. So that's like going to take me a day to get there. Yeah, it is. So I think the bigger question is, one, how has your company, how has your offering been able to be implemented with a combination of both on-site? I think people should make a visit, right? I think they should know where they're going and who they're supporting. But ongoing, I think they have to demonstrate that they've been able to have remote implementations, remote support, remote training, in addition to their on-site work. Because it's costly to send people out, right? And if they, oh my God, it costs so much money, they won't do it. And if they don't have built the training and capability on the remote side, that's going to fail. So that would be my observation. The bigger question is, how do you see blending on site, and how much do you require with remote, telepresence type of training?
Thank you. And maybe that's a good point of like clarification, and we can definitely record that for requirements. But thinking about the applicants on who's going to be applying, like what is the sweet spot for the actual sites that's going to be receiving the funding to indicate that they're ready to receive it and that the staff would be willing to participate? Kind of like on the other end of that, and thinking about Chad, your comments on we need to make it easy for them to apply. So maybe we're kind of lenient, but what is a good measure or signal that the organization would be able to use the funding, spend the funding, implement the ambient AI tool with proper support from the vendor that's chosen?
So I know taking that on as a third party is challenging. Having someone else come in and say, we're going to ensure your success. But I would say this piece is the piece that I think will struggle the most, more so than the technology choice. The piece that will end up making the difference is whether or not the organization is supplied the resources necessary to help with change management and understanding how to use the technology and how to get adoption of the technology and sustain the technology. So if there's an option to build that into the RFP, I think that would go further than having people attest that they're ready. So I don't know that there's a site out there that's going to attest that they're not ready.
Right. Very much so. We'll work on that one. We'll think about how that might be incorporated.
The thing, this is beyond, I think, the scope, but one thing that we might consider, let's say there are 3 suppliers that meet all the criteria and really want to compete. You could look at, is there and I don't want to introduce more complexity, but is there an organization that wants to support those and will embed people in Western Kansas and Central Kansas, and or has people that are already located there. So there might be, it's not to be decided now, obviously, but there might be. In fact, I know some firms that are in the consulting side that say, we only do rural, man. We'd love to be out there. We've got people in Phillips County, or and I'm not saying they do, but there might be opportunities to actually build up some local talent that could be good employment. We could have a lead hospital that takes it, and we train some people there and then make them available to deploy, so it becomes a much more efficient deployment model. So, I think this affords us some other opportunities to get leverage and scale that we might not otherwise have.
Thank you. Yeah, that's a tough question. But as you think about it more, and we can definitely take a look to see how that's been operationalized too. Thinking about this did come up earlier, but patient volume, financial needs, population served, these are just a few other things that can be incorporated into eligibility. So we have a few questions for you to consider. Should there be a minimum or maximum volume of ambulatory encounters? Should an entity's financial position or the degree to which it serves underserved or high need populations be taken into account?
Well, I mean, on number two, I think, and the Chad or others that or the community mental health team, I don't think financial status alone, but I think we should be mindful. Um, Actually, I think we do it based on the community need. If we start wanting to judge people's financial position, I think that shouldn't be this group, looking at financial need. I think you should look at what the express community need is. Is the minimum maximum? I certainly think definitely don't think there's a max. Minimum is they should be serving. I think, you should ask people what they're doing. There should be more than one. But I don't know that I'm qualified or if we think about what the min max are, but I think it's difficult to do the financial assessment. I think we look at community need, not organizational, financial position.
Yeah, thinking about maybe some of the provider associations or providers on the call. You have any other additional thoughts?
I guess, for number two, maybe my mind goes to why is that question being asked, maybe? So is that concern like, again, if I'm playing devil's advocate, you know, um, will this facility be around to even be able to support this in the future? Is that kind of the concern? Why that question is being addressed?
And not necessarily a concern, but some of these things are just questions that would, typically not even on this topic, but maybe addressed in RFPs, especially around making sure that, there's no like negative, for instance, no, negative marks on an audit or things like that, just to ensure that the funding is going to be used and that they're used to abiding by, state and federal regulations, for instance. Also thinking about, equity and understanding different population needs in terms of what, we heard maybe it should be based on what the community's needs or what the population needs. So if there's individuals or populations that experience greater health disparities, is there a preference for, funding these tools to assist with those population outcomes, health outcomes? And so these are just food for thought. You don't have to answer any of them, or if there's not a preference, it's okay. But it's just to kind of spark discussion. Yeah.
Yeah, so most of these orgs, okay, I think financial viability, we have so many of the organizations. I mean, Chad publishes this regularly, hospitals that are at risk. So I think if they're eligible to receive Medicare, Medicaid, and they're still a going concern, I don't think we should have anything on like financial viability. I think somebody else decides that. I
Make it the OIG's problem.
Yeah, that's right. I just think that's beyond the scope of where we should be evaluating eligibility. I do think there are, hospitals have to do these community needs assessment, but the whole program's already said the need is rural communities. Now, I think your question is, do we break this down into really, really needy people within rural communities? And again, I think then you're putting a lot of value judgments. I think you got the high level. How many people are you serving? Are you in a rural community? That's the cutoff that was talked about earlier. I think to get granular below that for round one, I think is pretty tough. I think the need is great across the board. I don't know, maybe in future scoring mechanisms, you take a look at areas that are underserved, like they click 3 boxes, beyond just being in rural. But I'd say for this early round, I think we're just trying to get technology out into this rural community and demonstrate that a common program with sustainability outcomes and those things is the objective.
And I'll support that. And I forgot who mentioned about we want broader folks to apply for this, right? And so making it too stringent and granular seems more counter to, I think, the initial the group of applications that we want to receive. So along with that thought.
Okay, any others have thoughts on that? Thank you for your comments. Okay, so I'm hearing make the application as easy as possible and as broad as possible while keeping rural the focus. Okay, all right. Next, we wanted to get your thoughts on the commitment to interoperability, sustainability, and evaluation. This is an important question, and I may have my colleagues on the call jump in on this one if needed. But the question around this is, should grantees be required to participate in an interoperability commitment and or data sharing agreement? If so, what requirements should be established? So for example, there could be a pledge or a commitment that applicants or grantees would have to commit to in order to receive the funding. And I can turn it over to Marty to explain this concept and how campus has an opportunity in this area to lead.
Yeah, my level best. But this is a broader question for the ETC beyond just the requirements for this specific initiative. But as RHTP dollars are being deployed to support technology, we know that one overarching goal is to promote interoperability. And so that the assumption is data is available as needed for the patient, as opposed to my holding the data because I view that as my patient. And it's a significant cultural shift that is necessary to support a well-functioning continuum of care. I think in Kansas, as compared to other states, we are very lucky in the regard that there is not so much of this data capture attitude. But certainly there's a need for the technological infrastructure to support interoperability. And so the broader question is, as we spend these dollars, should we follow the lead of CMS, which is expecting now different provider organizations, payer organizations, technology firms, to take a pledge to support interoperability. Now, not necessarily with the specificity of the CMS pledge, which identifies certain CMS sponsored networks and the like, but a more general statement that that we as an organization are committed to making sure that data is available at the time the patient needs it and flows as freely as possible. Again, nothing necessarily enforceable as part of these grants, but certainly a high level of awareness that dollars used to support technology must be certainly not at odds with the goals of interoperability. Kristen, anything to add there?
No, I think Marty, you covered it. It's really more about painting that picture we want to get to in year 5. And we've heard the word sustainability multiple times. It's that idea that we are creating that infrastructure so that wherever that patient is seen, the care team has access to the necessary information to give the best care in that moment. And so how do we start to lay that foundation today for building towards that in year 5 and beyond?
I love it. I mean, I think Marty knows we talked aside. I whether it's a pledge, if they get CMS dollars, which they do, they're actually more than pledged. They're participating. I think this is a really good statement about how serious we are about the data moving with the patient in context. Because a lot of data moves now, it just doesn't get put back at your next venue of care. Because, there are a lot of barriers to that. And there's still some vendor barriers that people don't like to talk about, but they're still there. So yeah, I think it's a great idea. A pledge is fine, that keeps it light, but I think it makes a strong statement that better care is delivered through better information sharing. And that this whole program is designed to get the right information at the right place at the right time so that we can live longer, live healthier, live better, and hopefully lower the cost, which nobody ever talks about, but I'm hoping someday that will happen.
Thank you, and thanks for explaining the thought process behind that. Are there any thoughts about something like this? And that example is just food for thought, and we can continue to workshop that during our in-person meeting. But in general, is everyone thinking that this is a good thing to include in an RFP or a condition of funding?
I think we put it just like Marty said, and it doesn't say one way or the other. So yeah, I think it's perfect.
Okay. All right, seeing a lot of thumbs up. Okay. The second question is a little bit harder, and we may need to punt this to our in-person meeting, but should grantees be required to participate in evaluation activities? I think that's probably easy to answer, but if so, what reporting requirements and measures should be used so what does success look like for the ambient listening AI or ambient listening RFP?
And just to know for the group, CMS has been pretty supportive of qualitative measures, and not necessarily just the hard science of data collection, certainly when that's an opportunity, but a number of the measures the states put forward overall for its plan, several have been qualitative, so opinion-based, survey-based, those have been well received.
Well, I would point to Chris and Aaron, some of the others that have implemented or are implementing. You have success criteria when you do your capital budgeting. I think whether it's the breadth of use, how many providers use it, how many notes are in. You guys also have some pretty good data on it improves the quality of the note, and hopefully leads to more appropriate reimbursement. So I think I think you definitely want an outcomes framework, a value framework here. And of course, the qualitative stuff is physicians happen to like it, and they say they like their jobs better, and they spend less time at home documenting, and they spend more time with their eyes on the patient. So that stuff's all really, really important because it all gets at provider satisfaction within a rural community, patients feeling like they're connecting with their provider. Those are qualitative. But the real output is it's better documentation, and hopefully it gets paid more fairly for the time that the physician or the other provider is putting in. So I would point to or ask our people that have done this on the call, what their experience is. But I think there's plenty of good measures out there, and I think it should be part and parcel to the money.
So
Yeah, so
I'm sorry. Go ahead, Chris. Sorry.
Oh no, I'm just going to kind of walk through a few things. So we broke it down. Obviously, is to start, we focused on physician burnout, and so we hyper focused on making sure that measure of time that they're doing things like pajama time or usage of time spent on EMR, and try to calculate, make sure that we're reducing their documentation time. So that's kind of where physician burnout. We also have a methodology that we use to do some research around cognitive burden as well. So how do you look at does it actually alleviate, rather than physicians trying to remember at the end of the day what they talked about with the patient? Now are they able to remove that cognitive burden? So there's a scientific methodology to be able to measure that. And so those are some of the user providers, and including the volume of usage, right? So number of notes generated, number of hours saved, and those types of things. And then also we try to equate to, did that lead to better patient outcomes? Are you spending more time making sure you're able to truly think about patients perspective, additional safety and saving those time and brain power to really think about the patient. Is there going to be a better outcome? So those are just the high level things that we look at. And there's a lot more metrics we track, but those are just some of the ones that come to mind.
Yeah, no, I would say that Chris and I have it a little bit easy because Epic surfaces a lot of that usability data and how well the physicians are documenting, and pajama time, as he mentioned, time documenting after hours. So that makes it a little bit easier for us to be able to measure some of the success criteria around an initiative like this. But overall, just the number of providers that are utilizing it, I think, is key. And then just the other thing I'd say is we haven't pushed this at all. It's just been organic in terms of the growth. But we have also seen people try to adopt it and not do well with it. At which point, either they ask for help, or they go back to documenting the other way. So, just a few comments.
Notwithstanding all of that, because we do the same thing, but what we do also, and this is probably not the greatest way to look at it, but we look at it from a billing point of view, is how soon they got their note finished and how quickly it was billed. It's not a great measure, and yes, it's more of a monetary measure, but it does at least tell us that it is helping them to get done faster. And the sooner a note is finished, the more it actually helps with patient care. Because, for example, if somebody actually has been seen today and then by chance they have to go to the emergency room later on, if that note's already complete, it just really helps everybody at that point.
Thank you. And Tatiana mentioned in the chat, what about measuring the quality and accuracy of the notes? So the accuracy of the tool, and we will make sure to get that incorporated. Okay. Well, we'll continue thinking about this. We'll document everything. And if you have any other thoughts on measures, please send it our way. That will conclude our eligibility discussion for today. There are a lot more details to work out, but this was really helpful in helping craft that section. I'm going to turn it back to share our slides, and we will continue moving into the requirements aspect. So we're going to focus the first part of the discussion on requirements to use cases. And so this is intended, now we kind of know who's going to be eligible, or at least have a good idea of who's going to be eligible for funding. We're now going to say, okay, let's talk through what's going to be used for and what should vendors be required to do is to support those grantees that will receive the funding. So I am going to turn it back over to Kristen.
All right, well, I got probably the easiest piece here because it sounds like everyone that's on this call already has a really good understanding of the ambient listening and documentation tools. For the sake of laying out the RFP, we're really going to be focusing on listening, documentation, and then we will look at what additional functionality, meaning the coding and next best action, can be layered on top of it. But for the sake of the initial RFP, it's going to be predominantly on the listening and documentation. And being able to love this last piece of the conversation, we will go much deeper on what are those core KPIs that we want to capture. We will make sure that goes into the RFP so that we're also having each one of those selected vendors be able to demonstrate success in those areas. And Erin, your comment to providers that have challenge when implementing it. In just a couple of minutes here, we want to start hearing more of the cultural and some of your operational challenges or what we want to be thinking through. But pausing a minute on ambient documentation, assuming this is not new for anyone on this call right now, given the conversation that we've had so far. Is there any question we can answer specifically behind this use case that hasn't already been answered for everyone? All right, well, we have short time to jump in, and just as a caveat, we're going to spend some time going through questions. We will also be sending out an assessment after the call. You will see that part of what we've gone through live today is at the bottom of it. If you've already answered everything you wanted to answer in the call today or the meeting today, you can skip through all of that. It is also there to be able to give you an opportunity if there are other thoughts that come to mind. But the top portion of that is going to go into more detail on your technology and systems today so that we can get that assessment that we've talked through a couple of times to understand what that current landscape is. So I think we can go ahead and just jump into talking through really what are some of those problems and what does success look like.
All right, thanks, Kristen. Okay, so we are going to go through this together. So I am going to ask Carson to pull up a poll. So we're going to take it together and then we're going to open it up for discussion. And we have the first section includes what the problem and what success looks like. So what problem are you most looking to solve with ambient listening? Rank your top 3 with 1 being the most important. I'll give you a minute or so to take this. You should be able to see it on your screen.
Shayna, this is Chad. I'm having issues where I thought I'm filling it out, but I can't click the submit button.
Yeah, same.
Oh no. Okay, some of it's working. You can just shout it out. That's fine.
Yeah, I think you have to fill out each individual one and rank it whether 1, 2, or 3.
Ah,
Thank you.
that's there you go. Thank you.
Too fancy for me. Thank you. Okay. So far, it looks like documentation burden and provider burnout. And then after hours charting and quality and completeness of clinical notes are kind of tied for second, but also coding accuracy and revenue capture. Let's see what else. Oh, patient experience, more face-to-face attention. So patient experience and documentation burden, provider burnout. All right, I'll give a couple more seconds. And then we'll go ahead and end the poll now. And in addition to those, are there any other problems that you were thinking about solving that weren't listed there?
So Sheena, quick question. Chris, you mentioned something about cognitive load and how you're measuring that for providers. Would that directly tie back then to accuracy, or how else are you measuring that? How are you seeing that translate?
So we used a NASA methodology on how they used to measure cognitive load for astronauts. And so our team kind of copied that methodology and really work. So it was a research paper that was actually published as well. And so we then took that and measured it with our physicians. That was the initial pilot. And so that's kind of what we're using. And so I connected with the physician who kind of led that effort. And then also then, there's some surveying component to this. So the physician and provider user feedback that also aligns to that. And so happy to connect offline and connect with the team that helped to develop and manage that.
That would be great. Thank you. I think there's interest to see how we could tie that back into this as well. It gives it a very unique perspective.
Yeah, and the hard thing I think is direct tie back into did it improve quality and safety, and those are all always going to be difficult. There's a ways to kind of maybe get to some of those things, but yeah, so that team has thought through kind of some of those end-to-end measurables.
Okay. Well, and if you have any other thoughts on the problem, but in the interest of time, please include in the chat what you think success looks like. So 12 months in a year after this is released, how will you know it was a success? There's a couple of examples there, but you can go ahead and also think through for whatever problem you felt like was the most important to address, what would success look like? I think we talked a little bit about that before in the measures too. All right, let's move to the next slide. So thinking through what would make this a failure or cause providers to abandon the tool. There's been some discussion around, oh, they went back to doing the old-fashioned way or how they were doing it before. What are some of those challenges that might be encountered to make that might be the case?
One thing that we observed is you actually do need to make sure that the practice of informatics and user feedback is important, right? So these are learning technology and systems. So whenever there's a back end upgrade to the model or model training, there are some changes in behavior that you have to make sure that you have users who can quickly identify and provide a feedback to address and fix, right? So there's going to be some, and the other thing is, I think, a lot of these models are now for ambient dictation, learning different specialties. So, primary care and different, family medicine setting, works well. But as you get into more of the specialty types of setting, it does get, depending on the tool, I should say, there may be additional, location specific or user specific or specialty specific, learning that it has to go through. And so if you lose providers who initially didn't work out as well, then they'd lose interest and the number of usability starts to go down. And so, just making sure that setting the right expectation and having the workflow identified to improve and the tool and make sure the specialty providers aren't having a bad experience up front, but they continue to work through it is going to be important.
And I see Aaron in the chat, he says, number of providers still using it, they will only keep going if it's adding value.
Yeah, I think that's the simplest metric. But in regards to something Chris said, in terms of the different technologies out there, ambience becomes so broad that I don't know that belongs in just one bucket. It goes back to some of the comments in regards to these funds not being available to folks that have already implemented ambient as well. You may want to think about what that actually means, because I understand the rules around the grant funds and that you can't be benefited for something you're already doing, but there's within ambient so many different users and so many different use cases that I think it demands some investigation and thought, I guess.
Aaron, before you go back on mute, you also mentioned that there are some of the providers that during that implementation have a hard time implementing and either they reach out for help or they quit using. What were some of the most common reasons you saw or areas that you saw challenges that caused them to reach out for help or
it requires a different way of running your visit with a patient. It requires you to adopt a little bit more of a structured approach to how you talk and the questions that you ask and how you ask them to be successful with it. And some people, I think, could make that switch easily, and some people struggled a little bit more with how to do that.
There's a comment in the chat around pushback or concern from patients. Has that been a challenge or a factor in pausing or not wanting to use the tool?
It's funny, you know, a lot of conversations end up, you know, speaking about that, about the concerns of patients. We have not experienced much of that. I'd be interested, Chris, and others who have implemented, whether you've seen any of that. I mean, on occasion, a patient will say, "No, thank you, we don't want this turned on," but it's pretty rare.
The next
I'm
question.
wondering,
Go ahead.
this is Tatiana, to comment to that response. Are patients aware that that's being used? Is there's a
Yeah, we're required by
they're
policy.
required? Okay.
You know, I I raised this I think one of the other meeting last time. I might be one of those patients on behalf of a family member that asked, did the provider know where this was going? And the only encouragement I would give to the provider organizations is to arm the people using ambient with a little bit of information like, oh, you know, we have these protections and things like that. And I'm delighted to hear that people aren't objecting to it because I think it's game-changing technology. But I think we should just make sure that, you know, they're not just like, I don't know, somebody from IT handles that. I don't know, which is the answer you get a lot of times when you put stuff in front of a user. So that's just a small thought.
Yeah, so making it clear that they have to have a process for notifying the patients and all of that stuff, or how to answer questions about it, that might be helpful.
Yep.
Beyond the clinical workflow and impact, what would need to be true for ambient listening to demonstrate that value? Thinking through the sustainability component.
What if we said it slightly differently or asked it slightly differently? For those of you that have it today, what would be the response of your providers if you said tomorrow ambient would be going away?
I've had, you know, physicians literally say, I will pay out of my pocket to make sure this goes, right? And you know, and I can give you some direct quotes, which was part of our training is, right, we have, you know, direct quotes from users saying, you know, I was burned out and thinking about moving away from practicing, and now this has complete, you know. So again, I think the idea is that we need to capture the voice of our users to make sure that that's continuing. And then, you know, we you know, a lot of different ways to measure, but we do track, right? So unique users and number of notes generated along with all the others things, so that making sure that individual user usage or percentage continues to be maintained or going up, right? And so, like I said, I think, you know, I think Aaron mentioned this, that you know, ambient dictation tool is evolving in a way that there's a lot of other feature that are now being added, and so those, you know, features should add value as well. So as we're sustaining it, making sure we're not turning on features and functions that are not adding value as we continue. But really capturing the voice of the user is, I think, tremendous to encourage those that are on the fence of using it. So I think those are some of the experiences we have had.
One additional question behind value, and again, this comes back to at the end of year 5, how do we ensure that it's providing enough value for these facilities to want to continue that investment? How are you seeing it used as, or how critical is it as a recruitment tool for recruiting providers and APPs to your facilities?
Again, just anecdotal, but you know, it's been a tremendous recruiting tool, and as new providers start this, you know, now they're asking for this to be part of their onboarding experience as well, right? And so, If they've used it somewhere else, then they definitely want to make sure this is in place before they come.
I would agree. In 5 years, everybody's going to want it, no matter if we have it or not.
Oh, Sheena is muted.
I said, thanks, Wyatt. I said, unless there are other thoughts on this, I think we'll move us along to the next question. All right. So there's two parts to this, to the barriers in section. So we're gonna make a poll go live now. What do you believe will be the biggest internal hurdle to adopting ambient listening at your organization or the organizations you represent? And if you already have it from your experience, what was the biggest hurdle from your perspective? I'll give you about 30 more seconds. All right. It looked like provider skepticism or change fatigue was the top of the list, followed by compliance, legal, or governance review of AI tools, then IT bandwidth or integration complexity, followed by patient privacy concerns and consent workflows. Okay, I'll go ahead and stop sharing. So any comments or thoughts around those choices that you all picked? All right. Kristen, do you have any follow-up on those? Want to dig into any deeper?
So with compliance, legal, and governance review being one of those top two responses, I think it feeds really quickly into that next question that we have. But for those of you that mark that, what is that just general compliance, regulatory, security take the longest, or very specifically as it's relating to innovation and AI?
I'll just say the thing that came to mind. This is Leland Bardsley of KTHE. Um, was something that I believe maybe Aaron had touched upon earlier, was sort of what does ambient mean? What's being done actually with that technology? And I think the more that it's maybe involved in supporting things like clinical decision making, then the question becomes, okay, is this data leaving the facility and going to some outside third party in order to create that decision and generate that recommendation, for example, versus an in-house sort of model that's already being able to just dictate what is the speech patterns, for example.
Great, thank you. Is there anyone else that marked that can speak to how quickly your compliance, legal, governance review is moving along with some of the innovation versus still really struggling with some of the AI tools that are being implemented?
I don't know if this is helpful, but we didn't see this as a barrier, because I think the initial approach we took is that we used kind of a NIST framework to be able to really have these AI questions embedded into how we assess from a cybersecurity and IT perspective. So we really led with that, and partnered with our GC and others, and so really that we went ahead and addressed those concerns as part of our standard way to look at AI tools or product. And so that really alleviated a lot of the concerns up front. So it never became a problem because you addressed this up front.
All right, great. Thank you, Chris. Sheena, I'll turn it back to you.
All right. So the second piece of the barriers and governance question, the poll is going live now. Does your organization or those that you represent have an existing policy or process for AI tools in or recording patient encounters, including patient consent? Give you a minute or so to take it. About 30 more seconds. All right, I'm going to end the poll. It looks like either yes or in development. So for those of you know that it looks like there's not a no response. So for those of us on the call, either have a policy or one is in development. So I'll turn it over to you, Kristen, for any clarification or elaboration.
I think the only question I have is for those that it's in development, is there value, whether it's for this use case or as we look at the future use cases, in defining kind of standards that we want to be applying to all of our RFPs and our potential vendor community? Is there benefit of sharing what some of the other systems or facilities have from a policy perspective that has been facilitating implementation of AI products that would be beneficial for the broader group to share and developing their own, or creating kind of a standard set of here's how we're approaching it so that we can also then provide that to our vendors. Not something we have to decide today, and we can dig in deeper in the in-person unless anyone has any comments, but definitely an opportunity to learn from one another, especially those that may be further advanced. And I guess that one further question to that really quickly, for those smaller facilities that all of you support or provider groups, do you believe that they have something established, or would it be beneficial for them to have something that could be shared as kind of a starting or a standard to be able to use?
So yes, I'll speak up, and I do think there would be benefit for sharing with smaller facilities. And I'd like to see what some other sites have done, because I know what we have, but I don't believe it addresses exactly ambient listening in the provider office.
Great. Okay. So we can certainly take that and think about the best way to approach that and pull that into part of our conversation in the in-person session for the next meeting.
Yeah, I brought this up about the leverage you want to get in this program and the services that you can provide to the provider community. I think whether it comes through the hospital association, whether it comes from the FQHC association, I think there's a real opportunity to not reinvent the proverbial wheel here. Because you've got some early adopters. I mean, KU gets credit nationally for being one of the first organizations to evaluate and adopt this at scale. And I know Chris and his team have, they've been on panels and talked about it a lot. And I don't know Aaron's experience or some of the others that are here, but I suspect you already have, some people that have been through the entire cycle. On the legal side, I think part of what you want to offer up is, look, guys, you can wordsmith this, you can hire your local attorney, and I know there's a GC for the hospital, but look, this is best practice. You should take it and run with it. Insert the name of facility. Okay, we're in Kansas, we're in the United States. There's a common approach to this. I just hope we can get to that, because I think that's the speed at which you want to be able to move forward. That's just one aspect. I think there's so much learning that's already been done. We should be packaging that up for these sites so they can accelerate their value.
Thank
And,
you.
and,
Oh, go
and
ahead.
Kristen, and I know we talked about maybe doing a kind of some of the metrics and success metrics. And so if you want to also follow up with me, it's the same group that also we happy to share kind of our policy and how do we do the patient consent, because we through trial and error learn what worked for us. I don't know if that'll work, but we'd be happy to kind of lay out what some of the ways we approach that as well, so that same group can help provide some documentations and how we approach it.
That would be great. Thank you, Chris.
And likewise.
Thanks. All right. Thank you so much. A great discussion. We have a couple of just housekeeping things, one more task that we have to get through and before we end today. So we will, at our in-person meeting, get to a few of the things that, just continue refining what the RFP might look like and get into the requirements for vendors. But now I just wanted to preview the Rural Health Summit discussion. So I'll turn it over to Kristen.
Great. Thank you. Really quickly, just want to make sure everyone's aware of this and can put a hold the date on your calendar. So as part of the Center for Rural Health Innovations partnership with CCA and working with Kansas in the RHTP, there is a 2-day Rural Health Summit that will be held in St. Louis in October. It's going to be October 7th and 8th. And there are spots for 75 registrations as part of this program that we're working through. So we will send out a link after this. It's an opportunity to come network with other states and their rural healthcare providers, as well as some of the different governing bodies in different states that are managing the RHTP program, as well as CMS. Additionally, as we spend time talking through in these meetings, identifying what some of those major pain points are that are specific to rural providers or rural healthcare, we will also have panels of innovators that are specifically there to address what those pain points are that have come up out of the first 3 meetings that we've had, and again, the remaining meetings that we'll have leading up to October. But it's a great opportunity to network, to learn from one another, and we'll have some use cases from multiple different states on what are some of those early successes for year 1 and what are some of those big plans for the year 2 RHTP budgets. So really quickly, I was trying to fit that in as quickly as possible. Happy to answer any questions that you all have. A registration link has been put in the chat. You can go through and also share that with any of the providers that you support. Again, there's 75, and once that 75 is full, there are additional spots for registration, but the first 75 are covered by CCA. So happy to answer any questions you have on that. And if we can jump to the next slide really quickly, I'm going to get us in under the 30 seconds. We are also going to be offering up 2 webinars to ETC, and we can expand who the attendees are for that. But wanted to get all of your quick votes on what would be some of your top 2 selections for webinar topics that would be beneficial information to be sharing with rural healthcare providers. You can also send over or put in the chat any other topics that are not on here that you would really like to see. We will be hosting the first one here in the next month to 2 months. So we will use all of your info to be able to go ahead and determine what that topic is and who those experts will be that will be hosting the webinar. So thank you very much. I think I got it all in 2.5 minutes, Sheena.
Record time. Thank you so much. Yes, very much. And if you have any questions about any of those things, we'll include a summary in our meeting summary and also in our materials. You'll have all the links and information for the upcoming summit, and we can solicit additional feedback for topics from the webinar as well. Looks like, just quickly, there's a tie between how to make vendor decisions about AI, best practices for authoritative decisions with AI, harnessing data to deliver real-time decision-making, and change management.
Perfect.
Thank you so much. All right. And then finally, I did want to just let everyone know again, we're having our in-person meeting, which is our next meeting on July 29th at the Kansas Health Institute. We'll be sending out a registration for RSVP. Lunch will be provided. Please attend in person if possible. But a virtual option will be available if needed. So please reach out to me separately if that is something that you'll need to do. Together, we will finalize the feedback for the RFP, and we will spend the bulk of the time setting the vision for year 2 and beyond for the group's work, and starting to really draft and complete the draft of the work plan and budget, and just talk through together what success will look like for the group's work. So thanks again for an engaging and great discussion today. And the next time I see you, I hope it will be in person. So look out for those details and information about that meeting coming up at the end of July.